So Dr. Mollee is one of our leading haematologists in Brisbane and certainly in Queensland, and has done extensive work with amyloidosis and myeloma, and has an amyloidosis clinic at Princess Alexandra Hospital, but has also done a lot of research in myeloma. And Dr. Mollee has come to speak about future treatments in myeloma. So appreciate that.
Thanks, sir. Okay, so this is the history of myeloma here. The first documented case, Sarah Newberry, back in 1844, was described. Terrible disease back then. Untreated myelomas got a median lifespan of only about 6 to 9 months back then. Nothing could be done. She fractured about 12 bones in her body and died after a year or two. And then another case was described when they found this Bence-Jones protein by a doctor in London called Henry Bence-Jones, and he gave his name to this protein that the myeloma makes. Anyway, they had a number of things. Treatment: rhubarb and orange peel, not very successful. Steel and quinine. So anyway, it was described as a cancer of plasma cells around 1900. They worked out that it was what the description was, and it changed from myeloma to multiple myeloma in the early 1900s. And then melphalan, the first treatment, 1958 was used, the first chemotherapy treatment. So the first treatment that made a difference to how long people with myeloma lived. And then a variety of things changed. These are the treatments that have come along over the years. And more recent time, a bit of an explosion: thalidomide, then bortezomib, then lenalidomide. At the same time, advances made in understanding what myeloma is. How does the cancer work? What makes some myeloma behave differently to others? So I'm going to talk briefly about what we call asymptomatic myeloma, and then focus most of the time here on symptomatic myeloma, that is, myeloma that needs treating. Talk very briefly about when myeloma comes back and what we call high-risk myeloma. And this just really relates to the current state of where things are at. And then the second part of the talk will be about new treatments. So this is asymptomatic myeloma. So not all myeloma is causing trouble. And asymptomatic myeloma refers to when we find the myeloma cancer present, typically in the bone marrow, but it's not causing any trouble. It's not affecting the bones. It's not affecting the kidneys, causing calcium problems or anything. And in fact, what we currently do at the moment is we just monitor that situation. That is by blood monitoring, seeing how someone's progressing. The reason for that is that at present, early intervention in myeloma hasn't been shown to improve outcome. This is a bit of a difficult thing to understand sometimes, but if you think you get a cancer diagnosed early, you should get in there quickly, fix it up, and Bob's your uncle, your outcome will be better. But unfortunately, the treatments available to date haven't been good enough to make a long-term impact that actually makes the outcome better. Because chemotherapy is toxic, and because most people in this situation don't need treatment for an average of 5 years, there's no reason, in fact, to rush into chemotherapy. Hopefully, though, one day we'll have some drugs that actually are effective and not toxic, so that maybe you can make an impact. But at the moment, we're not quite there. So it's observation with looking at starting treatment, hopefully just before the myeloma causes any real trouble, before it causes problems in the bones, before it causes kidney trouble. So it does need close monitoring. This is what we've got for symptomatic myeloma, or that is myeloma that needs treating. We've got chemotherapy, which we've got the old chemotherapy agents. We've got the new ones, which are sort of widely known as the novel agents, but they're not novel anymore, so no one really knows what to call them. And then there's newer agents as well. Stem cell transplant still got an important role in myeloma. And I'm not going to talk too much about the rest of these, but radiation, treatment of the bone disease is very important. with some form of biphosphonate. Sometimes surgery or what they call vertebroplasty is required. Supportive care like psychological counselling, palliative care is often very important, and the role of support groups. I'm just going to talk about these up the top. So firstly, just what transplant is for those not familiar with it. Autologous stem cell transplant works in myeloma, but it's a very blunt tool. It's basically using the highest dose of chemotherapy that the body can tolerate to knock the myeloma down as low as possible. So myself, I can't see it as being the future of myeloma therapy or any therapy, in 20 years' time, but at the moment it's very effective, it works, but hopefully we'll have something better. So what happens in a transplant is that you give a dose of chemotherapy that's good for the myeloma, but completely wipes out the normal bone marrow function. And then you rescue someone from that by putting back stem cells that you've collected before. It used to be called a bone marrow transplant, but we don't use bone marrow anymore. It was found that you don't need most of the bone marrow, you just need special cells in the bone marrow called stem cells. And then it was discovered that in fact you could collect those stem cells out of the blood after some growth factors and chemotherapy. So we don't do bone marrow transplants for myeloma anymore, we do peripheral blood stem cell transplants. So this is what happens. Someone gets a stem cell collection on an apheresis machine where the blood comes out a tube, goes through the machine, the stem cells are picked off and the rest of the blood goes back into the body. So that happens after chemotherapy, typically cyclophosphamide in Australia, and GCSF injections. Then those stem cells, which appear in a little bag, they get frozen, stuck down in a fridge. They can stay there for decades if needed. So they're just pulled out when they're needed. So someone's then given the high dose of chemotherapy that's good for the myeloma, usually melphalan, and then the stem cells are taken out of the freezer and given back just like a blood transfusion. They find their way to the bone marrow and produce all the blood again. So what has the action in myeloma in what we call an autologous, using your own stem cell transplant, is the chemotherapy. The stem cells are purely supportive. There's nothing magical about them on the myeloma at all. So that's the stem cells. So this is what happens. You have the chemotherapy. The stem cells are put back the day after the chemotherapy. Your normal blood counts go right down. And then the stem cells start to grow up and they start to produce the blood again. So if you didn't have the stem cells, your blood counts would go down, they'd never come back up. So the stem cells enable you to give this big dose of melphalan. The other major pillars, if you like, of myeloma treatment now have moved on from chemotherapy, and they refer to these so-called novel agents, thalidomide, lenalidomide, also known as Revlimid, and these two together are known as the immunomodulatory drugs, because they have got some effects on the immune system, so it's a historic sort of name. And in fact, there's new ones in this class coming along. Pomalidomide is one. Then there's the proteasome inhibitor, which is called Bortezomib or Velcade, also a highly active drug in multiple myeloma. And again, there's new ones coming along here. So these agents are all individually very active in myeloma, more active than traditional chemotherapy drugs. And typically, though, the best results are when they're combined with often a standard chemotherapy agent like cyclophosphamide or melphalan, or with prednisone, so a corticosteroid. So a typical recipe has a combination of 2 or 3 of these sort of drugs. So thalidomide, it's the drug that was used initially in pregnant women for morning sickness and as a sedative, caused the babies with the little arms. Went off the market for a long time, and interestingly made a comeback. It's a very interesting story if anyone ever wants to read it. A patient's wife wanted to do something for her husband who had very advanced myeloma. Nothing was working. She rang researchers in the US, bothered them endlessly, and eventually found someone that had found that thalidomide worked in acute leukemia, of all things, in a laboratory. She said, "Why, let's try that." And she found a doctor who was prepared to use it. And so they developed a trial protocol and used it in the US. Unfortunately, her husband, his myeloma was too advanced and he died before it could do anything. But they had the drug there for a trial and they gave it to the next patient and his myeloma vanished. And that led to the reintroduction of thalidomide as an active agent. So all because someone's wife wouldn't give up on them. So that's very interesting. Anyway, so it's typically used with other agents, chemotherapy or steroids, generally 50 to 200 milligrams. It's good if you've got kidney trouble, but it's got side effect problems. Peripheral neuropathy, so it affects the nerves, causes constipation, blood clots and tiredness. And of course, it's tightly regulated because the government wants to make sure that it never gets into the hands of a pregnant woman. Then there's lenalidomide, the next generation of this family, which was developed initially, in fact, to try and get rid of the effects on the unborn baby. And they weren't entirely successful, but it is more potent than thalidomide. And again, given with other steroids and chemotherapy, given in this schedule of 21 days out of every 28, so 3 weeks on, 1 week off, whereas the thalidomide's given continuously. In Australia, it's available for only when the myelomas come back. It's not available as initial treatment. And Bortezomib, first type of drug called the proteasome inhibitor, given traditionally intravenously, but more recent and in fact widespread use now in Australia is giving subcutaneously, but there appears to be less side effects if you give it subcutaneously rather than intravenously. So it's given in lots of funny schedules, twice a week for 2 weeks and 1 week off, or it can be given weekly, and again, weekly Bortezomib is becoming more widely used, mostly because of less side effects and more convenience. Again, very good drug in when the kidneys are affected, but also problems with affecting the nerves. Peripheral neuropathy can affect the platelets, can cause trouble with the blood pressure dropping. So some of the things that are particularly good about these drugs, sorry you won't be able to read this down the back, but when the kidneys are affected, Bortezomib and thalidomide are very good because they're not taken out of the body by the kidneys. Sometimes if you've had blood clots or heart issues, then the Bortezomib can be the best situation. For some types of myeloma, the Bortezomib and the lenalidomide are better drugs. So depending on an individual's particular circumstance and situation, this can sometimes dictate which of these treatments is optimal. There is a guideline written for Australia by haematologists interested in myeloma, and it can be available online if anyone wants to have an in-detailed read of what I'm about to tell you. It's primarily meant for doctors, for haematologists and oncologists, but it is freely accessible. So this is what sort of happens at the moment in Australia generally. Patients are viewed as being suitable for a transplant or not. And if you're suitable for a transplant, you have some initial chemotherapy, and this recipe CVD, cyclophosphamide, Velcade, dexamethasone, is the most widely used regimen in Australia now. So over 90% of people are being treated with this. Velcade or Bortezomib only got funded for this indication a year or so ago. CTD was the favourite before then. So you get some chemotherapy initially to get the myeloma under control. Once you got some response, you proceed to the Autologous AU stem cell transplant, and then plus or minus some sort of what's called maintenance after the transplant. In Australia, that's most commonly thalidomide, sometimes with prednisone. So that would be not the only, but the most widely sort of followed strategy. For people who are not up for the transplant for a variety of reasons, it's typically Velcade-based or thalidomide-based chemotherapy. So you can see how these new agents are sort of standard practice now. And there are trials to support this practice. So melphalan, prednisone, Velcade, or cyclovelcade, dexamethasone, probably the most widely used recipes. And then melphalan, prednisone, thalidomide, or cyclophosphamide, thalidomide, dexamethasone, all of them chemo drug, thalidomide, steroid combination are the most widely used. And they tend to go for, around a year of treatment. So firstly, to transplant or not, the transplant eligible group worldwide is roughly, this is 65 years or less, transplant, older than 65 not. But it's not a strict age thing. So Some people are 50 and not up for a transplant. Some people are 73 and are up for a transplant. So it depends not just on the age, it depends on, in fact, your assessment of biological age. So some people, as you know, you'll know a 70-year-old that looks like they're 50 and they're going to be able to tolerate something a little bit more. Depends on comorbidities, so other illnesses. So if you had a heart attack recently, you're not going to be up for a transplant, too dangerous. If your kidneys are not working or some other health problems. And of course, patient preference. Some people just don't want a transplant. Some people do want one. And so that comes into the decision a little bit as well. So it's really an overall assessment of the patient as to whether you're fit enough and well enough to go down the transplant path or not. But as a rough rule of thumb, it often is around the sort of 65-year age where the risks of a transplant start to grow and become a bit unacceptable. So typically in Australia, 3 to 6 cycles of induction. The only thing I'll mention is that vincristine, not Velcade, an old chemotherapy drug that's toxic to the nerves. This is about the only real strong recommendation in this area was that it should no longer be used. People should be treated with one of these new agents now, so the Velcade or the thalidomide or the lenalidomide. So you want to use one of those, and which one you use depends on a lot of factors, including some of the things I mentioned before, plus, for example, whether you can get some of these agents. So the thalidomide and the Velcade are available at the moment, but the lenalidomide is not. So it's available, but it's not funded. So if you want to pay your, I think ends up probably somewhere around $20,000 because of a discount that the drug company's got. It's available through that. For transplant, it's certainly part of routine treatment still, certainly in Australia and most of the world, for younger patients with myeloma. 2 transplant in a row, it sort of underwent a bit of a vogue a decade or so ago, then it sort of went out of favour, and now there's some evidence suggesting that there's some types of myeloma that might actually benefit from it. But for most people, it's typically 1 transplant rather than 2 in a row. And there's a number of trials. I'm going to show you a few of these curves, so it's probably worthwhile getting your eye in on them. These are survival curves, so doctors look at these all the time. So here is the proportion of patients who are alive at any one point. So 100% you start off with, 75, 50, 25%. And then this is, here we got the number of months. So this was the very first transplant trial performed back in the 90s. So quite some time ago, almost 20 years ago now. And what you can see is that the high dose, this is the transplant arm, and for the first 3 years after the transplant, there was no difference in terms of how people were going. But then after that, the transplant arm started to do a lot better. And this was because the myeloma wasn't coming back. And in fact, from this original trial, there's still about 10% of people whose myeloma has not come back. That's a lot of follow-up. And it's raised the possibility of whether some people wonder whether myeloma can in fact be cured. It's typically thought of as an incurable disease, but maybe that's not the case. So there's been a couple of trials, in fact there's been about 5, that have shown that transplant improves long-term outcome, that is how many people are alive 5, 10 years down the track, compared to standard chemotherapy. The trials that are going now of course, because there's newer agents, are comparing, some of them are comparing transplant to the newer drugs, because the newer drugs are so much more effective. People are wondering, can you do away with the transplant? And the current answer is not yet, but we'll wait for the results of the trials. You can certainly see this is the number of transplants that are done. This was from 2010 in Australia, and myeloma is the commonest reason that someone has a transplant in Australia. So I'll say just a very quick word on allogeneic transplant. This is a transplant using bone marrow or stem cells from someone else, not your own. And this type of transplant is still considered investigational. That is, it's not routine part of practice and should preferably just be done on a trial. There's been more studies at the moment suggesting that it doesn't work than there have been that it does. So the exception to that is that maybe in someone very young, you occasionally see someone with myeloma in their 20s or 30s. And that's a situation where maybe it's worth taking the risk with a allogeneic transplant, a situation where normally the results are not as good as an autologous transplant. Consolidation or maintenance, so we've had your initial chemotherapy, your transplant, and then something after, and all three of the new drugs have been looked at in this situation. The best data at the moment is probably with thalidomide, in that there's been more studies done. It shows improved control of the myeloma in all the studies, and in half of them, people live longer if they get the thalidomide. The Bortezomib studies certainly controls the myeloma longer. We don't know if it actually makes people live longer though, and the same with the Lenalidomide. And there's a lot of debate about maintenance. Should you give it with or without prednisone or dexamethasone? Should you give it for 6 months, 1 year, 2 years? Because all the trials are a little bit different, and you've got to weigh up the side effects of the treatment. So some of the treatment people have a lot of, they struggle a lot with side effect wise, and so you've got to weigh up the quality of life you're getting versus the benefit you'll get out of it. But certainly most people in a most widely used consolidation in Australia would be the thalidomide. I think I've said most of that, I won't go over it. What about people who are not going down the transplant pathway? So there's been a lot of improvements here. So what was used previously was MP, melphalan and prednisone, the first agent introduced back in 1958. Nothing was better chemotherapy-wise until thalidomide came along in 1999. So lots of different things tried. But now these two would be the most commonly used sort of recipes in Australia, melphalan prednisone thalidomide or melphalan prednisone Velcade, or often the cyclophosphamide can be used instead of melphalan, so cyclo with Velcade or cyclophosphamide with thalidomide. So these are, they'd probably be how 80–90% of patients with myeloma are treated nowadays. I'll show you some information on Revlimid and dexamethasone. Very active combination, but not available or not funded in Australia just at the moment. So this is some of these survival curves. So basically, the top curve is generally, that's the one you want to be on in terms of treatments. That's the one where the disease is controlled, where you're living longer. And in this study, which was an interesting, it was patients above the age of 65, mostly 65 to 75, where they could get old chemotherapy, melphalan prednisone, or melphalan prednisone with thalidomide, that's the best one, or in fact a transplant with reduced dose melphalan. And the transplant didn't help at all, but the thalidomide did. It's one of the pieces of evidence as to why that combination is a standard treatment. Here's one from the French in people over than 75 years of age. There are very few studies in cancer in the 75 to 85-year-old age group. That age group's often neglected from clinical trials, which typically focus on younger. So this was a very good trial from the French, looking at melphalan, prednisone and thalidomide. That's the top curve again, showing improved control of the myeloma. This is progression-free survival, but improved survival overall. So again, a standard treatment. And then Velcade came along. This again in people over 65 years of age, and the curve up the top is the one with the Velcade. So you can see, for example, in this study, at 5 years, it's improved the number of people alive from 34% to 46%. So this is 12%, that is, my math's not very good, 1 in 8 people alive that previously wouldn't have been. And these are the sort of the typical advances in cancer treatment. You don't go from here up to 100%, but you get a little bit extra. And in fact, in cancer, to improve survival by 10% or more is very uncommon. So definitely a major advance getting Velcade. Here's a Revlimid study comparing the old melphalan and prednisone with the melphalan prednisone plus Revlimid, and the Revlimid curve doing much better. Another thing that's come out is that there's some evidence, in fact, that not only after a transplant but after initial treatment, there may be some benefit to having further chemotherapy in a maintenance way to try and keep the myeloma from coming back. It hasn't been consistent though. So the UK did a study which suggested myeloma control was better. I don't have the curve here, but overall survival wasn't actually better. That is how long people were living. So it becomes weighing up very much of side effects versus benefit. Bortezomib can keep the myeloma under control better, and so can Revlimid. But there's controversy amongst studies again as to whether these two strategies again actually mean you're alive for longer in the long run. The reason for that is that if you don't get the Velcade after your treatment or the Revlimid after treatment, you can get it when the myeloma comes back, and it works in that situation. I'll just explain what this is about because it's an important principle in treating older patients, and older in this context is, more than 75 with myeloma. When you get older, you can't tolerate the drugs like you can a 50-year-old. More side effects, more problems. And what's become very clear is that the reason that older people do less well is that when pushing on with standard doses of treatment, they get more side effects, and those side effects force you to stop the treatment. So it's become clear now that in fact it's very important to back off the treatment early, to stay on the active drug even at a lower dose, and in the long run that results in, one, you stay on the drug longer, but two, the myeloma stays under control longer. So this is a very important part of managing myeloma, is carefully looking out for the side effects of the treatment and making the dose adjustments early, not when a major problem's happened. That's basically what that says. Treating myeloma when it comes back. Back in the 80s and 90s, there wasn't a lot of focus on this because when the myeloma came back, there wasn't much that could be done. But in fact now, in someone with myeloma, the survival after the myeloma's come back is in fact it's a large amount of someone's lifespan. And that's because people can cycle through several treatments now. So it becomes very important what to do when the myeloma returns. Plus, almost all patients eventually relapse. So it's important to get some control of the disease to maintain some quality of life. But there is no standard approach. It's highly individualised. It depends on the myeloma itself, when it's come back, what worked the first time, what side effects have you got, what side effects do you want to avoid, what treatments are actually available. And there's a whole range of combinations, including, if what you gave worked really well before, you can just give it again. I won't go through that too much. So this is sort of a bit of an overview of what can sort of happen in myeloma. This is not a set sort of thing at all. But younger patients, often they'll get initial chemotherapy, transplant, maintenance. The myeloma will come back. They might get some treatment based on Bortezomib or Velcade. That'll work for a while. It'll come back. They might get Lenalidomide. That'll work for a while. It might come back, and then you've got these other agents which are coming along. So particularly younger patients who can tolerate a lot of treatment, patients often cycle through quite a number of different recipes over time. And then similar things can happen with older patients as well, in that when the myeloma comes back, the disease can often be rescued by a different sort of recipe. I'll just say one word about high-risk myeloma. So what's changed a little bit in the last few years is the recognition that some myeloma has got genetic changes in it that predict an increased likelihood of the myeloma coming back. And there's some knowledge now that particular drugs are good for that situation rather than others. So most people in Queensland now, when they have their bone marrow to diagnose their myeloma, will get genetic testing done on it by the laboratories. This is called FISH testing, fluorescent in situ hybridization. Doesn't matter what it means. It's looking at the genetic mistakes in the myeloma. And you may hear these things, that your myeloma might have deletion 17p or a translocation between chromosome 4 and 14. These are genetic changes which identify a type of myeloma that's more likely to come back more early. And these ones in particular seem to do better if you can get Velcade into the treatment regimen. So another factor that's important to dictate what sort of treatment's happening. The issue, of course, is that the problem is that while you've got these abnormalities, they don't apply to everyone. They're an average sort of thing. And so not having them doesn't mean that your good myeloma will always stay good. It can change and behave aggressively. Similarly, not everyone with these so-called bad myelomas actually behave badly. Some people do extremely well and their myeloma remains under good control. So the problem with identifying these things was that while as a group it identifies a group of myeloma that does not so well, in an individual it can't actually tell you definitely what's going to happen. There's a lot of other aspects to myeloma management I'm not going to run through. Patients with myeloma have reduced immune function, so a particular predisposition to infections. Infections are a big problem that needs to be prevented and controlled. Kidney problems are difficult, and a proportion of patients with myeloma need dialysis if their kidneys fail. Prevention of bone disease, bone pain, fractures, very important in myeloma. In fact, it's been one of the big changes over the last 20 years. The wards used to be full of people with advanced bone disease on morphine infusions, and we don't see that type of myeloma very much at all anymore. It's been a big advance, and that's related to effective chemotherapy and prevention of bone disease by bisphosphonates. So these are drugs like Zometa, Iridia or Pamidronate and Clodronate. And then there's management, obviously, of the side effects of the myeloma treatments. And there is no myeloma treatment which is benign. They've still all got side effect problems. So what's happening here? So there is positive news, and myeloma is actually, amongst cancers, there's actually a feeling of optimism amongst doctors in the last 5 years, and that relates to the introduction of the new treatments, but because we can see the enormous pipeline that's coming, and I'll show you some of that. So in the mid-90s, all we had was melphalan and prednisone. This little red bit here down the bottom, I don't know if you can see it down the back, but it's about 3%. This is the number of patients that go into what we call a complete remission. We can't detect the myeloma. It's not a cure, but we can't see it in the bone marrow or on the blood tests. So hardly anyone went into remission. And then when we get the new agents, thalidomide by itself, we see a few more people. Then Velcade, Revlimid, the combinations, we see more. You add a transplant on top of some of these active agents. There's one study with a complete remission rate of 72%. Now, we would never have dreamt of that 10 years ago. Myeloma had such a sort of negative feeling about it, but there's enormous strides made. This is not cure, but you're not going to cure someone unless you can get them into remission first. So it's an important marker of improvement. These are some other things to show that there are actually some improvement. This is Australian data up until 2010. You can see that this is the number of people dying per 100,000 population of myeloma, males and females. Males in blue, males always do worse in cancer than females, so that's just the way it is. So the rate of dying was getting worse through the 70s, 80s and 90s. Then it stabilised out probably through the introduction of transplantation, and then it's declining. This is a worldwide phenomenon that the death rate for myeloma overall is reducing. This is a study from Europe, one of the Scandinavian countries, looking at what's happened. This is for patients over than 65 years of age. This is, you don't like to think of your mortality, but this is the normal survival curve for someone over 65. I mean, people are dying, obviously, all the time. This is the normal population. So this is what the survival curve was like with old chemotherapy, melphalan, prednisone, or its like. This is since Velcade, Revlimid, and thalidomide were introduced. So it hasn't got the survival up to normal, which is what we'd like, but it's certainly made a major improvement. So there's certainly things happening.